It's my pleasure to introduce our two speakers today. First, I'll introduce Dr. Sam Lau. Dr. Lau is a professor emeritus at the University of Florida College of Dentistry. He's an advisor member of the Pankey Institute. He's a past president in the American Academy of Periodontology. He's a current officer of the Academy of Laser Dentistry. And Dr. Lau provides periodontists, dentists, and dental hygienists with the tools for successfully managing the periodontal patient. He was selected Dentist of the Year by the Florida Dental Association, a distinguished alumnus by the University of Texas Dental School, and has received the Gordon Christensen Lecturer Recognition Award. He's a past president of the Florida Dental Association and a past ADA trustee. Our second panelist and a dear friend of ours, Dr. Stephen John, is a periodontist with over 34 years experience practicing in San Mateo, California. He completed a postdoctorate periodontal program at the University of California at San Francisco in 1986. Dr. John is a member of the American Academy of Periodontology, California Society of Periodontists, the American Academy of Implant Dentistry, and is a fellow both of the Pierre Fachat Academy as well as the World Clinical Laser Institute. Dr. John implemented laser therapy in his office over 8 years ago and appreciates the advantages, the use of laser therapy in the treatment and outcome of his patients. He's also an Invisalign certified doctor and works with several local dentists in treatment planning cases and educating the public in general on the benefits of straight teeth and preventing periodontal disease. And with that being said, it's my pleasure to turn the program over to our moderator, Dr. Sam Lau.
Thank you, David, and really appreciate many of you coming out on a Friday, depending on your time zone. And thank goodness it is Friday for all of us. But as if you were with us on the Wednesday, I promised you that we would have a very candid, transparent conversation around some of the topics that we discussed on Wednesday, but really more focused on where lasers may fit in your practice, especially around the area of periodontics. It is really a treat, delight to have my colleague with me, Stephen John. We have presented many, many courses together. We have, I guess it's okay to say, we have had a few tequila shots along the way. We thought about having some tequila before this, but we decided that we would virtually have tequila afterwards. But he is very, very knowledgeable. The one thing you're going to hear from Steve is that he is definitely a wet-fingered periodontist. His dad was a periodontist. But we really want your questions, especially towards the end. And so with having said that, from Wednesday, there were many, many questions, and we just weren't able to get to all of them. So I thought I would sort of coalesce them into like 9 areas. Some of that we will actually answer along the presentation, but some of it we may not get to. So what are the settings for a diode with perio? We're definitely going to get to that, especially if you're a hygienist. Can we use chlorhexidine with lasers? We're going to get to that. How do you place hydrogen peroxide in a sulcus, especially pre-laser bacterial reduction? Piezo versus magnetostrictive ultrasonics. That's a very interesting one, especially now. There is definitely 50% less water in a piezo running at the same level as it is in the magnetostrictive. So as we move towards decreasing aerosols and considering aerosols, if you have a piezo, I must tell you that if you have the piezo and you turn the water to no more than 1/3, you're probably not going to heat the device. Water in a magnetostrictive is essential. There's no way you're going to be able to cool those stacks. But if you have magnetostrictive, it doesn't mean that you have to give up. It just means that you need to turn the water down until it's just warm on the stacks. Can diodes be used now? Absolutely. What about the plume? My friend, I have read every single study ever done on the plume and a diode laser. And Steve and I are periodontists. That means we're anal. I mean, we go crazy over research. And what we depend upon is really randomized controlled trials that could be in what we consider to be systematic studies. So this thing is all over the place. And in my mind, if you have, and we'll probably mention this again, I just did a presentation on returning, especially in the RDH operatory. If you email me, I'll give you my email at the very end. I'll be more than happy to not only send you the Wednesday presentation that we did, but I'll also send you the one that I did relative to what are we going to do about managing perio in the operatory now as we return. So there are really three areas. One is pre-procedural rinse, and again, I highly recommend 1% to 1.5% hydrogen peroxide. Cut it with your favorite mouthwash. Two, HVE, high evacuation, no matter what you do. Someone called me today and said, Sam, what if I just use manual instrumentation? Do I need HVE? I would do HVE on everything you do. Again, if you email me, there's some very creative ways now of creating HVE to where you're not having to really hold on to such a large, heavy hose. And then lastly, naturally, I don't have to tell you, we need to be doing PPE, but especially with our face shields. So what was the oral probiotic that we mentioned? It was Probiora. Probiora, Probiora Pro, Probiora Pro. Where can I get the antioxidant gel for wound healing? And I know that Steve uses this. It's Perio Sciences. So put Perio and Sciences together, Google it, and you'll find it. I'll have Steve talk to you about laser periodontal surgery. And where can I get laser training? Well, guess what? Buy a laser and I'm sure the company will give you the training. However, the other possibility is the Academy of Laser Dentistry. Academy of Laser Dentistry is a phenomenal place for get training. But by the way, good commercial companies have great training, and we'll talk about that in a little bit. We're going to set this thing up for you. As far as laser applications in periodontal therapy, we're not going to ignore anyone in this particular situation. But what we are going to do, and I'm going to challenge Steve on this one, there are going to be four things that we want you to leave with today. If you're going to purchase any new technology, especially if it is going to be in the arena of lasers, whatever you do, make sure that that laser has versatility, that it can do more than one thing, and that's why I think Steve and I both love all tissue lasers. Create a laser with the procedures that are fairly simple, straightforward, user-friendly, that you can integrate into the practice so that you are not going to keep that in the closet. Make sure that the laser that you have can produce the results, both from a science standpoint, also from an experiential standpoint from peers. But more importantly than any, especially right now, if you're going to buy something, my friends, there's got to be a return on the investment. And I'll have Steve also speak to that as we go through this. So let me just take a few moments and go through our what I call swim lanes. And you'll see our first swim lane. Many of you had questions, especially if you're a hygienist, about utilizing diodes in gingivitis and to a certain degree early periodontitis. So with that, here's your perfect swim lane one. For periodontal debridement / curatage, pocket depths 4 to 5 millimeters, calculus, dematus, works more effectively on single-rooted teeth, although you can do it on multi-rooted teeth, but not as predictable. Horizontal bone, a little bit better than vertical, and patients that are less compliant. And these are the lasers. Recently, BioLace just came out with something called the Epic Hygiene, but there are many of them out there. This is a 980, and it is now FDA approved for laser bacterial reduction. So make sure that your laser is FDA approved for these procedures. And there are many procedures that we do, but I want to concentrate on two. And those two procedures in that first swim lane for you is, first of all, laser bacterial reduction. Now, you can imagine that the average fee for laser bacterial reduction is probably around $30 for a full mouth. If you look at 8 to 10 patients a day and you're charging $30 in the hygiene laboratory, you have one hygienist, you can imagine what that would do relative to gross revenue over 1 year. And laser bacterial reduction, uninitiated tip, recommended setting, 1.5 watts, is a great procedure. One of my favorite procedures is laser curettage. Why? Because it opens up the sulcus and allows the hygienist now to go in with either a manual instrument or an ultrasonic and be able to literally do degranulation in that area. And also this becomes not just antimicrobial, this becomes anti-inflammatory at the same time. So when we take that laser and you're in that first swim lane, what you're looking at is the laser looking for a chromophore. That chromophore can be a pigmented organism, but recently I have really been pushing utilizing hydrogen peroxide, photolysis of taking hydrogen peroxide, 3%, right out of the bottle, irrigation syringe. One of our questions was, how do you get it in there? You can see over on the little photograph from Dr. Odor, great periodontist in Romania who created this great study for us, and he's got a few of them. But you're just taking a syringe and just irrigating in the sulcus. Now this is LBR, and then now you come back and you only need to take the tip and put it 1 millimeter into the sulcus. That's it. You don't have to go all the way down. Ensure it is uninitiated. And then you'll notice that the laser energy will now activate the hydrogen peroxide. By the way, as I mentioned before about pre-procedural rinse, the one thing that is coming out very strong is that the antiviral properties of hydrogen peroxide. So but using chlorhexidine, either in this day and time or also using it in a sulcus, has such minimal effect on what we do. And actually in a wound, it has a negative effect, and most periodontists are quite aware of that. So you've got LBR, you've got laser-assisted periodontal therapy. And so in that first swim lane for gingivitis and early periodontitis, you've got two procedures, $25 to $30 for a full mouth on LBR, $50 a quadrant, and again for your early periodontitis in addition to your SRP, and just wonderful, wonderful areas where this laser can be used. And here's a case. Here's our patient. They have almost moderate, but right on early. And so here we are on this is FluidaProbe data, VoiceWorks. Over here on the left, you see the pocket depths. Red is bad, black is good. And this is after we have done quality periodontal debridement and also lysing, doing the photolysis in the pockets with the hydrogen peroxide. Now, you will notice, and I'm sure Steve as the periodontist has noticed, that we still have issues in the molars. Now, when you do that, that moves us into this second swim lane. And in the second swim lane, when we talk about that, that is the general dentist out there. So we're not going to discriminate. We're not going to leave anybody out here. We got the hygienist in the first swim lane. We got you as the general dentist in the middle swim lane. And we have got Steve. Actually, this looks pretty good for Steve. We got Steve in the third swim lane. The bottom line is I'm going to have Steve have a conversation with you. I don't want you to be afraid of periodontal surgery anymore. This is not going to be blades and sutures. It's going to be early to moderate periodontitis. So Steve, it's called Ask the Expert. So take it away.
Thanks, Sam. Can y'all hear me?
We can.
Okay, good. So I'm going to switch over. Let me share my screen with you. All right, there we go. So in swim lane 2 basically is designed for the restorative doctor. So part of the restorative doctor is in choosing, if you want to get involved with perio and perio treatment, periotherapy, and everybody has a different degree of comfort zone in this. There are some people out there, they go, gosh, I really don't want to even probe a pocket. You have other individuals that are so comfortable, they could go ahead and do a full-on mucogingival surgery and flapping. The idea of the swim lane 2 is to get it so that the restorative doctor can treat some of these cases that either they want to kind of go expand their abilities a little bit more with perio, or the patient doesn't want to go to the periodontist, or many other factors, the reason why you want to go ahead and kind of extend yourself a little bit further, kind of go into a different part of the comfort zone. It's not meant to go ahead and make you to become a periodontist. And as we get into the swim lane 3, we're going to be describing that a little bit more about how that's more of an area that most periodontists are going to be involved with. But the swim lane 2 is designed for you to look at, diagnose, see those cases, you go, hey, I could go ahead and treat this. This is something that I could go ahead and doing. And part of what we're trying to do right now is to demonstrate these are the cases that you should be looking for. These are cases you should think about treating. These are the ones that you should be comfortable with. Part of what, again, in the presentation, we talk about lasers, and people always say, oh, look at this, it's a magic wand. You guys, it is not a magic wand, okay? Lasers are not all about the idea of picking up this wonderful thing is going to create this change. It's all about basic biology and basic physics. There's no magic to it at all, and that's what we're kind of go over with you right now. And part of taking courses or classes is understanding the different wavelengths of the lasers and also understand the basic wound healing or inflammatory process. So you understand what you're doing and why you're doing it and why you're getting the end results. So one of the things we're going to talk about is periodontitis, that the patient has some localized defects, let's say 3, 4, 5, maybe some 6 millimeter defects. We know that the fact that most of our defects are relatively narrow in the vertical defects, bony defects, the narrow defects have a higher probability of success. When we start getting involved with larger defects, we start getting involved with kind of more of a broader defect, a horizontal defect. Those are cases that actually are not very easy to go ahead and treat, and truthfully, they should be go ahead and managed and done by a periodontist. At least that's my point of view. But the easier ones, that the relatively moderate or mild to moderate types of bone loss, narrow defects, are great cases for you to go ahead and kind of delve into. One of the things, so again, this is the swim lane 2. One of the things that the BioLase has is actually the repair protocol. Repair protocol is basically a suggestion. It's a guideline for you to go ahead and treat these cases. It's kind of more or less a conservative idea, conservative view of getting involved with treating these. When I first started to do the laser therapy, I did a lot of these. I did the early ones. I want to become in my comfort zone. So I did a lot of the early cases, not the advanced courses. I didn't want to do the advanced cases. I still flap those. And even today, I will still flap some of the advanced advanced defects. So part of the idea of the repair perio is finding what's going to work best for you. So I'm going to kind of go over actually a case, or actually a couple of cases. We don't have a lot of time, unfortunately, to spend in great detail, but this is kind of like a wet your whistle. So when you look at that idea, when you look into different types of tips, most lasers have a straight tip, which means the energy is coming out pretty much in a straight line. There's a little bit of a divergence, pretty much straight line. With the water laser tip, they have a radial firing tip, which means the energy is actually 85% lateral and 50% kind of more of a straight line. So you're kind of doing more of a circumferential treatment of your pocket or defect. That's what makes this procedure, this tip so unique is the tip that's used. Here's a patient of mine, vertical defect on the meso of the bicuspid. We have about a 9 millimeter pocket, as you can see over here. Actually, push it down to about a 10 or 11. Lingual paddle side, I have about a 4 millimeter. So part of the repair protocol is is step oriented, and each step has a purpose, you guys. Every step is designed to go ahead and take on the idea of what biology, wound healing. So this is not just a haphazard, we're going to take some light, throw it on some tissues and watch the area heal. There's biology behind it. There's science behind it. So the first thing we want to do is remove the epithelial lining on the outer surface of the tissues. By removing the epithelial liner, it's going to prevent the epithelium from going back into the pocket. So we do kind of a sweep sort of a procedure to remove that. And you can see that as at first it started off as a light pink, as we slowly go across removing this epithelium, so we're gonna get down towards the connective tissue, which leaves, and it won't show up necessarily as as a dark red, more of like a lighter pink. And one of the reasons why, because with the laser therapy, you have less bleeding. And one of the wonderful things about utilizing the laser, the minimal amount of bleeding. You can see everything, okay? Whatever you do on the facial, you want to do on the palatal. The next aspect is that within this pocket, we have a lot of granulation tissue. Okay, so in the past, if you take as curette, you scale, root planing, and of course we call that inadvertent curatage. Well, we're going to be doing some definitive curatage. And if you think about the idea of curatage, it's like, oh gosh, that's a bad word. We don't do curatage. Well, I'll tell you, if you happen to have a wound, if you happen to have a cyst, you're going to go ahead and curatage the lining of that cyst out. So the same thing is, all we're doing here is removing that granulomatous tissue that's inside the pocket itself. You actually see little tiny specks here. Dark specks are coming out. That's some of the calculus that's breaking off. Yes, the water lasers can go ahead and disrupt or remove calculus, but honest truth is you still have to go back and do hand instrumentation. A lot of times we go ahead and people forget to go ahead and do the hand instrumentation afterwards, and that's why they get the failure. So even though that you are getting the calculus removal, you still need to go ahead and remove all the calculus. So right here, what I'm doing is I'm removing or disrupting the granulation tissue. I'm going against the bony defect, removing the granulation tissue, the bony defect. I'm slowly moving the tip around. Kind of keep in mind the fact that it's the tip that's doing all the work. These tips, these zirconiums are plastic. So if I put too much force on it, it's going to break on me. So you can see that I'm able to remove a lot of this tissue very easily and very effectively just by using the laser itself. Now, after I get through removing the the granulation tissue, I'm going to go ahead and start to remove a little bit of the irritants around the side of the tooth. Now, a lot of times people say that these are flapless procedures, okay? This is not a flapless procedure. We always believe if you cannot see it, you can't treat it. We do minimal flap of the papilla just far enough for you to look down on the defect. So as the procedure goes along, even though I'm staying fairly conservative, I now have a little mini flap where I can look into that defect. And actually at the time, I was able to go ahead and get enough of the blood products out where I can actually see the entire root surface. Now I'm going to go ahead and do my instrumentation. Ultrasonic scalers, if you like to use them, great. If you want to use a piezo, fine. Whatever works best and most efficiently for you. I also like hand instrumentation. Some people like it, some people don't. It all comes down to your comfort zone, making sure that root surface is immaculately and thoroughly clean. And that's the key to all this, is making sure that it is nice and clean. Once you go ahead and you get all the granulation tissue removed, you're scaling the root plane. I'm going to advance this just a little bit. I'll go ahead and do a little bit of flexion. I'm going to do some root debridement. We've created a smear layer on the root surface. I want to remove that smear layer. So now I have a clean defect. I have a clean pocket. I have the potential for regeneration. Now that I have the pocket here, here's a little bit of a enamel matrix end again. We're going to go ahead and do a little bit of cortical perforation. I ultimately want to create holes in the bone to establish a bleeding pocket. So again, I can utilize my laser to go into a little bit of a higher energy, create these cortical perforations, and now establish a bleeding pocket. With firm pressure, we like to use periacral to go ahead and keep that area, the papilla together. We do a little bit of pressure and allows you to go ahead and get essentially, it's basically a primary closure. With that primary closure is going to allow for optimum healing, okay? 3 months later, if you take a look, again, this is a fairly gentle probing. I'm getting about a 4 millimeter pocket, getting this gentle probing because I don't want to do any definitive probing for sometimes up to about 6 months to a year. So again, we have very gentle probing. So this is actually a very quick, very simple way of doing things. Somebody happened to ask about the idea of sutures. If you do a minimal reflection papilla, just the idea of the compression papilla is going to allow you to go ahead and get the primary closure. If you're concerned about it, put a little bit of periacral on there. If I have more of a reflection, then I will put sutures. I'll be honest with you, I rarely put sutures in these cases, in these situations. So this is an example about how to go ahead and utilize the repair protocol for a relatively simple defect. The question is, a lot of times, can we do multiple defects? You can, but it becomes a little bit more difficult. So when you start off these, treat the localized defects. This is a case, again, that it was relatively simple. It had a very deep defect. It's actually 12+ millimeters localized pocket, exudate, a lot of irritated tissue in that area. I decided to go ahead and do repair rather than to go ahead and flap it. This was purely by way of repair. Went in there and cleaned it out. Ultimately, about a year later, you can see radiographically that I was able to go ahead and get some regeneration of the bone, not 100%, but I think it was pretty doggone good for what I was able to get. So this would be a perfect example of a swim lane 2 example for something that I think any restorative doctor they can go ahead and do. And we're now into swim lane 3. Sam, back to you.
Steve, let's talk a moment. So why did you remove the epithelium at the very beginning? Because as I look at different laser protocols, I rarely ever see anyone talk about removing epithelium on the outside of a sulcus.
So when you have healing of the defect itself, what happens is that you ultimately want to get regeneration. In order to get regeneration, you have to have the blood product, you have to have the regenerative cells in the pocket. One of the things that will hinder or slow down that regeneration is epithelium. Epithelium will prevent the potential of the bony products of the connective tissue to go ahead and go back into it. So by removing the outer layer of the epithelium, it allows for, once you remove that outer layer, it grows about 0.5 millimeters a day. So it's going to be a relatively slow regrowth until that epithelium comes back up into that gingival margin. The hope would end up being is that you remove enough of the epithelium, you get enough of the clot to organize, and the idea of regeneration that once the epithelium gets to that position, it's not going to go into the defect itself, so therefore you get optimal regeneration.
And so if I heard you correctly, then you're taking the laser after you've done your instrumentation, and I would agree, it's up to the clinician. But then you went in and you used this particular laser, which is an erbium chromium YSGG laser, to literally remove the smear layer. And what was your rationale again for that?
Ultimately, the smear layer is going to decrease the ability of any sort of regeneration. If you want to think about the regeneration of either a new cementum or reattachment or readaptation of the tissues, if you have the pores, the tubules clogged up, you're going to delay the potential of that. So by go ahead and removing the smear layer, you get ultimately the optimum potential of regeneration within the defect.
And so you really are removing the anxiety of where someone says, well, I don't want to do one of these closed flap procedures because I really can't see in there. So when I was watching you, when you took like a curette or small elevator, you were able to actually see the bone. So you weren't just blindly going in and decorticating, you were literally watching what you were doing, especially with the loops, I assume.
Definitely, with magnification, especially because you can't do it without magnification, I can see all the way down the base of that pocket. I mean, ultimately, I could get in there. And the nice thing about utilizing the erbium chromium YSGG laser is that, like as I mentioned, is that ultimately we want to get some bleeding up from the bone. I can create perforations by go ahead and put it into a higher setting to create the kind of like the osteotomy of the bone to allow for the bleeding.
And so this might be for our domestic friends in the United States, maybe not so critical for our international viewers. But the other reason when we talk about billing, in the United States, there are descriptors when you're utilizing third party, and the descriptor to get the maximum reimbursement, as you should, because this is really surgery. I hope you're appreciating this is not a non-surgical procedure. It's just not a flap and osseous procedure. But one of the other reasons for this is the descriptor says you really do need to see bone, you need to work on bone, and you need to reflect a flap. So to get the maximum reimbursement here, you should be doing at least a mini flap here to be able to visualize the osseous. So you're going to move that papilla just far enough to where you can see the osseous and be able to do, what you need to do. So I'll go back and take a look at my screen here. Perfect. And so now that we have looked at the early to moderate, and I really want to reinforce with you, and I'm a periodontist, Steve's a periodontist, but what we're suggesting to you that before I would see a patient, stay in your practice and getting some type of halfway done because of deep pockets, not because of your abilities, then leave your office. This is where you need to be taking the opportunity to be able to do these procedures in your office. How many times have you heard, "Doctor, can you do it? Doctor, can you do it?" And then we're going to mention here in a moment about those cases where you do not feel comfortable with, then moving it to another arena. So when you want to do periodontal surgery, it's different from swim lane 2. It's minimal local factors, fibrotic gingiva, multi-rooted, angular bone loss. And this is where the erbium chromium YSGG, or erbium laser, comes into play. You notice that when Steve was using the tip, that tip was actually almost identical to a periodontal probe, and that allowed him to be able to really manipulate, and he described at least one of these tips. So if you're going to purchase a laser, make sure it has the versatility of being able to get into the pocket, to be able to get into the areas where you need to be to make this happen. And so when you do that, if we move now into swim lane 3, because if you look at our maxillary right central, now that's a fairly good defect there. Now I did do this with a mini flap. By the way, there's going to be research. I can tell you, there will be quality research in quality periodontal journals, I would assume, that's going to demonstrate that there's been articles before, but there's probably in the future, you're going to see good randomized controlled trials that demonstrate that what Steve just did is going to be the same as far as clinical parameters in the future. However, well, Steve, let me turn it quickly over to you. You did flap and osseous surgery before you got into this business. How many years have you been using laser?
For about 8.
So you have both, you've done flap and osseous surgery and you've done this. Now I know it's sort of, I'm prepping you, it's rhetorical because I know what your response is going to be, because it's the response of many periodontists. Do your patients take opioids when you finish these procedures?
No.
And what do you get them?
Anti-inflammatory, a couple Advil, a couple Tylenol.
They get up the next day, they go to work. That's what patients want. So therefore, by the way, just want to let you know, because you're probably thinking about this. By the way, I noticed that when you were using your laser, I didn't see a lot of water.
No, not that much.
And so, by the way, those of you who are listening to us, no one has seen this, but BioLace, we just did some comparisons. And if you look at a high speed, you're looking at 50 milliliters per minute. If you look at a erbium chromium YSGG, so there's 80% less water with aerosol using a erbium laser with 50% water. I'm not talking about decreasing the water over a high-speed handpiece. Just as an aside, you do know that a erbium handpiece laser will also do restorative. So you might want to be thinking about that, because aerosols have become such a predominant part of our conversations. So with the moderate periodontitis, what condition should I consider referring to Steve? Not just because I like him, not because he gives me turkeys at Thanksgiving and gives me, what's that tequila you like to drink?
Don Julio.
Don Julio, very expensive. I hope his wife's not watching, because she always is watching my credit card when we go out. That probably ruined the night, but that's okay. Probing depths greater than 5, probing depths deepening, request general implants, requires special periodontal surgery. Now, before I go any further, because I don't want to get into the politics here, and Steve and I are very much in line, but do you know that if we only got severe periodontitis, Steve and I would be working 7 days a week. So please understand, if you feel comfortable doing the very severe periodontitis, take our courses and we'll be more than happy to show you. But I'm going to turn it back over to Steve. And now I would like for you to just move one step level, understanding that it may be periodontists that are doing these procedures, but for the most part, how would we do, when I consider swim lane 3, it's not just necessarily periodontal, Steve. What it is really severe periodontal disease, and can you use a laser?
All right, thanks, Sam. So let me get back into oh, there we go. Can you guys see that? So a couple quick things. One is that, the question comes down towards is that have I pretty much thrown away my scalpel and things like that? No, I haven't. Okay. I still go ahead and flap areas, still pick up the scalpel, I'll still pick up my gingivectomy knives and things of that sort. So if you're a periodontist, I'm trying to tell you, you're never going to go ahead and utilize your scalpel ever again. I'm telling you that's wrong. There's many cases though that I do find that I now have to go ahead and utilize my laser rather than utilize the scalpel. In addition, that there are many times a procedure that I'll utilize only the laser tip and not any other instruments. So I'm not telling you to go ahead and throw those instruments away. What I do though is that in the past is that even if I do go ahead and utilize my scalpel to maybe do a reflection or do a little bit of tissue recontouring, whenever I come to degranulation, I'll always pick up the laser. The laser is very efficient at removing the granulation tissue, number one, but also it helps decrease any sort of bleeding during the procedure. That's one of the things that you're going to see when you start getting involved with the idea of the erbium chromium YSGG laser, is that when you go ahead and do your surgeries with this laser, you have very, 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 very minimal bleeding. And it's pretty amazing how it looks and what the results are. It's like almost night and day difference. So let me see if I can flip that. This is a case I did. Obviously, look at the bone loss on that tooth. Ultimately, the question was, how are we going to go ahead and deal with this? The patient really wanted to go ahead and keep the tooth. If I extracted it, I would say, oh my gosh, how am I going to go ahead and deal with that defect? How am I going to place an implant? So ultimately, I was happy with the fact that the patients said, can we try to save it? I go, yeah, that sounds great. So I decided it's a perfect case for me to go ahead and utilize my the erbium chromium YSGG, ultimately the repair protocol per se. Now I didn't want to reflect it because part of it is you saw the mobility is almost a classroom mobility. I felt that if I had reflected this this tooth or this area, that the tooth would have come out with reflection itself. So this is purely a flapless procedure. This really is. We always say that we want to go ahead and do a little bit of reflection to get in that area, so you can see underneath it. I did this pretty much flapless. When you get involved with doing these curatages, ultimately you can't find that when you dry it off, you can't look down the root surfaces. So majority of the treatment that I'm doing here is primarily removal of the granulation tissue. Now, this actually was a defect, again, that actually, I think I saw the patient about 9 months after it was discovered. It was trying to be treated with root planing. It was trying to be treated with antibiotic. So about 9 months after they decided or they determined the patient had this problem. So this was not like an acute defect. So most periodontists would say, yeah, that's an acute defect. It's going to heal no matter what you do. It did have a little bit of longevity behind how long it had been present. So this is kind of more of like between a quote chronic and an acute type of defect. So the first thing I'm going to do is remove all the granulation tissue around the tooth. As you see, the first thing I did is remove the epithelial lining on the outside. As we say, that's the first step we want to do so we can prevent the epithelium from migrating back in. Now I'm going to go ahead and remove the granulation tissue around it. And this took a while, by the way. This is not something, these videos, I'm sure you realize I've kind of shortened these. This is not how long it took to do these videos. This is a procedure that took me a good 45 minutes at least on this one tooth. So it's not something that you just kind of go whoopee-doo. You really want to make sure that you go in and get the job done. So I'm spending a lot of time on instrumentation, ultrasonic. I like hand instrumentation, particularly in this type of situation, because I feel like I have a lot more tactile sense. And that's pretty much what I use the hand instrumentation for. So ultrasonic, here's the hand instrumentation. So primarily what I'm doing is removing the granulation tissue, removing the irritants, getting the area so I have a fresh root surface. And that's what's going to be the debridement, as Dr. Lau mentioned at that one portion that I was utilizing the laser to remove that smear layer by removing the granulation tissue. By prepping the area, I now have fresh tissue, fresh tooth, fresh root to go ahead and get some healing. All I really wanted to get on this tooth is just to get it so that there wasn't any exudate, that the tooth maybe would stabilize a bit, maybe I get a little bit tighter adaptation of the tissues. I was hoping to hopefully decrease the pocket a little bit, but unfortunately I didn't know if that was going to occur or not. So I didn't have a lot of high expectations, and neither did the patient with this. I did put a little bit of the enamel matrix derivative on that area. I did put a little bit of Periac to hold the tissues in place. And I put a periodontal dressing in there to decrease the mobility. I hadn't planned on doing splinting ahead of time, so my dressing was now my splint. So here's 1 week later. So you can see that the tissues are a little bit pinker. Here's a month later. So again, a little bit less magenta, slightly more recession. I didn't create that recession, okay? Here's a year later. So a year later, that's the radiograph. Now, I'm not going to tell you I got regeneration of the bone. It looks like it, but I'm not going to say that because unless I flap it and do a little histology, I don't know. But that sure looks like bone to me. Mobility, I got maybe a minus on it where I had a 3+. Look at that recession that the body did. But now these are more probing. I'm getting about a 3 millimeter. No, I'm not doing that light probing where you just kind of like just put the probe in there and not putting pressure on it. I'm doing standard pressure probing. I'm not using a probing that's thicker than the other one, so it's not going to go as deep. So this is true probing depths of what it looked like after the procedure. So I got some pretty incredible results with this. Now, a lot of times people will say, yeah, that's that one case in your 35 years of practice that you're showing us right now. These are the kind of cases, honestly, that actually, while they're not always the norm, they happen a lot more times than you would think. So I've now gone in from taking these cases, these pockets for people who ultimately want to keep the tooth, from saying, oh, we got to extract this, saying, why don't we try this? And getting a pretty fair number of great results that people are pleased with afterwards. So this is actually a case I wanted to show. Again, this is a case I would not have flapped in that area. Part of what we're trying to show you guys is the idea of conservative therapy, minimally invasive. Everything is going towards minimally invasive these days. And that's really kind of what my practice is all about. I've been kind of like the minimally invasive guy. If I could do as minimal amount of trauma to the tissues, to the patient, that's the route that I want to go. This was a before and after case. Okay, you can see that the defect actually almost went all the way down to the apex on this tooth. I did the repair protocol. By the way, I did bone graft it. Okay, I had a little bit of a sulcus in here, shoved a little bit of bone in there, and here's how it healed up. So yes, I do modify things based upon what I feel is the best treatment at that point. Part of it ends up being is my decision as a periodontist, realizing I don't think this is going to get the result I want to get. I need to do a little bit more help with it. So therefore, I decided to go ahead and do a little bit of bone grafting. So even with these advanced cases, gun gardeners out there, periodontists, I'm going to tell you right now, one of the hardest things to do is try to convince a patient. They walk in and say, you need to have periosurgery. They say, great, let's go ahead and do the surgery. And ultimately, they'll say, Dad, I don't really want to do this. But if you tell me to use a laser, the patient acceptance is huge on this. So swim lane 4, I'm going to stop this. Sam, back to you.
No, I would tell you, we've got about 5 or 6 minutes left before we have some questions. So I would like for you to now talk about some periimplantitis, if you don't mind.
You got it, no problem.
I do want to leave some time for questions, so you have about 5 or 6, 7 minutes to talk with something I think is a major part of what these lasers do, and you do it exceptionally well. So if you would take it back to you to share your screen.
You bet. All right, so this actually, as you know. This, I'm sure, as you know, is actually a subject that's going to last kind of 2 or 3 or 4 days. So with this in mind for periimplantitis, if we're getting involved with implants, we need to make sure that we evaluate the etiology. You want to make sure that you decontaminate that implant surface the best you possibly can. And we need to make sure the surgical site is optimum for healing and regeneration for more maintainable implant. Ultimately, if we're going to go ahead and do the treatment, we want to go ahead and return the implant surface to biologically compatible. I want to try to do a touchless procedure so I don't alter the surface. And whatever we use, we have to make sure that it removes not only the soft tissue, but also the hard tissue deposits on the implant surface. When we look at all of our options for implant surfaces, ultimately, the laser, the Erbium Chromium SGG, the Erbium YAG, the CO2 lasers are the only lasers out there that can address hard tissue, hard deposits and soft deposits, and still go ahead and maintain this surface. Keep in mind that all implants, there's different types of surfaces. And imagine the idea of trying to scale or curatage this surface with there's bacteria or calculus underneath there. With the laser, it's very effective in removing the deposits on there, the zirconium. If you happen to take the course, by the way, one of the things we do is we take an implant, we put some dental stone on there and let that sit for a while. Believe me, that sucker is hard to get off. And we have the participants take the side firing tip, a very, very specialized tip, around the implant itself with the stone on it, and watch as it breaks away that hard deposit, okay? This is not a procedure that's gonna take 30 seconds. It takes a little bit of time because it's slowly breaking away the hard deposits on the implant itself. So ultimately, again, I don't have a huge amount of time as we take this to go ahead and remove it. If you take the course, here's what we have you do. And look how efficient that is. Look at that implant surface. I mean, there's not any pitting, there's not any trauma to the implant surface. And we're taking a laser to go ahead and remove the deposits. Again, I have a kind of a decision making. Unfortunately, we don't have a lot of time for that. Part of it ends up being implant repair. If you have an implant that has about 2, 3, maybe 4 threads exposed, here's I have a case where I have a 9mm pocket around the implant itself. So I decided to go ahead and just do the repair. I didn't want to flap it. I didn't go in there, so I'm gonna do my gingivectomy first. Look at the palate, no bleeding. Is that beautiful or what? Okay. I mean, if that was like a scalpel, I'd have bleeding everywhere. I'm gonna remove the granulation tissue around the implant itself. Okay. I'm gonna use my side firing tip, wonderful tip. Gee, I think there's somebody on this this webinar is one that designed it. Was that you, Dr. Lau? So side firing tip, the wonderful thing about this is you can move the tip. And you see me here so often practically take that tip and with this little handle on it, move it. So I'm taking the energy and putting it 90 degrees to the part of the implant that I want to go ahead and end up treating, okay? So take it, move the tip around, and clean up the implant surface. Make sure it's not any hard or soft deposits. 3 months later, I've got about a 3-4mm pocket. Okay. Granted, the tissues are a little bit tighter or better adapted to the implant. So I've reduced the pocket by doing that. Case I did 9 months after placement, had a lot of granulation tissue around it. There was exudate. Patient was aware of it. I was thinking, oh, I'm losing this thing. Just some antibiotic therapy, no change at all. Went in there to go ahead and utilize the erbium chromium YSGG repair protocol. 3 months after treatment, I was getting regeneration of the bone. No exudate. The patient was happy. I don't have a 1 year on this one yet, but again, just by going to do an early intervention with the laser, I was able to change a condition that I was going to ultimately get failure to my implant to something I have success for. I already mentioned that one of the wonderful things about the laser is the degranulation. So around implants itself, we have a lot of dense connective tissue, granulation tissue. It is one of the most difficult types of tissues to go ahead and remove. A lot of times we'll have like these little lacunae of bone, the granulation tissue has gotten into it. And lacunae, it's hard to go ahead and remove that granulation tissue. So with the erbium chromium YSGG, I just take and rub it around the defect itself and slowly start to separate. Again, keep in mind, this is plastic. If I put too much lateral pressure, it's gonna break. So there's hardly any pressure at all. I don't have to go ahead and take my curette and scratch or scrape around the bone to remove this. It is breaking up the granulation tissue on the surface of the bone itself. Go ahead and remove it. Take it out on the interproximal, and ultimately go ahead and remove the tissue. And my assistant's gonna suction away. There we go. And it's gone. Now look at these implants, okay? I don't know about you, but that actually isn't too bad. That doesn't look good. That doesn't look good. There's something hard to deposit on there. Probably an oxide layer. If I want to get any sort of healing, regeneration, whatever I want to do, that's got to go. I can take a curette to it and scale it, but honestly, it's going to scratch up my implant itself. So why don't I go ahead and take my side firing tip, take it on again. Here's the contaminant on there. I'm going to go right around that edge of where the implant is, and slowly start to chip away the hard deposits. Is breaking that hard deposit away. If that was calculus, it would chip away. If it's an oxide layer, it'll chip it away. And that's, of course, you think, well, that's a relatively smooth surface. Now we're going to get into threads. And again, the far more challenging. If I took a curette to that, it's going to be a huge challenge to go ahead and remove it right around that thread area. This takes a while to do, you guys. It's not something that we just jump right in to do. So you can see that as I'm slowly moving around to break up the oxide layer. About 30 seconds into this. Again, this takes a little bit of time. I'll speed up a little bit. All right. So go ahead and remove a little bit of the hard deposit. You see that it's starting to break away, chip away. Ultimately, I'm gonna get it exposed. And look at these implants. They look much, 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 much better. So before, here were the hard deposits, the oxide layer. Afterwards, is a far better, far more biologically compatible surface for if I want to replace the flap, if I want to go just do some regeneration. So is a far healthier area. We're not going to be talking about gingivectomy since we don't have the time for it. So Sam, back to you. All right, Sam, you're on.
I'm getting there.
Oh.
So you did mention, as we go back to perio, we're not recommending what biologic you use, what osseous augmentation, but you saw Steve using Imdigang. You saw him using bone grafting. If you're a PRP or PRF person, be our guest. But on these big, especially these big, broad three-wall defects, as he mentioned at the beginning, it is not a magic wand. Don't forget the core basics of what we do and why we do it. So now would be a good time, David, if you could, or Nathan, and if we could have maybe some questions to
Sure.
close out our time together.
Yeah, I'm happy to do that, Dr. Lau. And before I do, thank you to both you and Dr. John for what's been a very, very engaging presentation. Lots of positive comments about the cases being shown and the techniques. And it's been a really nice hour with you both. So thank you. Just a couple of minutes left. And I know, Sam, that you did quite a bit against the questions we received on Wednesday. But one of the themes in the question and answer panel so far has been what a diode can do and can't do as it relates to some of the procedures that you and Dr. John are showing. Where might you use a diode for perio treatment versus the waterlays that you primarily showed? There's a number of questions sort of asking about that.
Sure. And again, I don't want to oversimplify it. And Steve, please chime in as we talk. But swim lane 1 is your diode. Swim lane 1 with your early periodontitis, possibly your gingivitis with laser bacterial reduction. Not to say that you cannot use an all-tissue erbium laser for early periodontitis, but I consider swim lane 1 in those states, especially where, from a regulatory standpoint, a hygienist can use a laser. That's where the diode works very well. A diode, and Steve, again, I think using a diode for moderate to severe periodontitis, I'm not so sure you're going to get any further than if you were using a scalar, curette, or an ultrasonic.
And I'd agree with you, Sam. I think that one of the things too is that, there are lots of procedures that we can do in perio utilizing the diode. You can do gingivectomies, your frenectomies and stuff like that. I got to tell you, once I got the waterlays, the water-seeking laser, there's like a night and day difference. I mean, I won't even go back to utilizing diodes for most of those. Pretty much the diode in our office is for laser bacterial reduction, maybe a little bit of localized curatage. But if I'm going to do anything more than that, I'm going to pick up my waterlays. It's just so much more efficient, more superior. And I think even for patient comfort, it's a lot more comfortable for the patients too.
Excellent, thank you. I think we have a live question or two perhaps that we'll get to, but maybe one off of the list while we get that set up, if you don't mind, Dr. Lau.
Sure.
There's a question from Nora about tips breaking in the sulcus. They've had some experience where tips have broken. Any recommendations to avoid this?
Well, Steve mentioned it quite a bit. Again, I don't want to jinx anything, but I rarely have ever had a tip break, either diode or erbium in a sulcus. You just have to be careful, understand your root anatomy. Steve, you mentioned quite a bit that these were zirconium tips, the clear ones are sapphire. You just have to be really careful with knowing root anatomy. These are not a scalar curette. When Steve and I teach quite a bit together, one of the things that we have the hardest time getting over, folks, is they walk in and they want to use the laser like a high-speed handpiece. They want to use a laser like a ultrasonic or curette. You're defeating the whole purpose. The laser energy is what's working. So if you are breaking tips off, one is you may be using the tip longer than you should be, but secondly, you should be gentle and allowing the laser just to be in the sulcus. Let the energy work. There's nothing you need to do but get it there. Steve?
Kind of think of the idea of laser as being a paintbrush. So ultimately, if you're going to do very, very, very fine painting with maybe about 4 or 5 bristles, you can't go ahead and put a lot of pressure on that. It's very, very gentle. Everything is just a very light touch. I mean, literally, it's a light touch. There's hardly any lateral pushing at all. It's all just by if you're kind of like take your tip and push it lateral, it's bending. You got to back it off, and you got to do a little bit more gentle. So my suggestion would be, if you're breaking tips, back off, go a little bit slower and a lot more gentle.
Excellent. Thank you very much to you both. With the help of our colleague Nathan, I believe we have a live question from the audience from Dr. Nina Madavi. Dr. Madavi, can you hear us?
Yes, I do. Can you hear me?
Yes, thank you. Go right ahead.
I was wondering if you happen to know the ADA code for laser bacterial reduction?
Great question. Unfortunately, there are no laser codes for just about anything in dentistry, with exception of maybe TMD treatment and possibly aphthous herpetic lesion. So this has to be basically out of pocket or bundled into the treatment that you do. I wish it wasn't the case, but I must tell you that as we work with practices, if you phrase it right, and if you email me, I'll give you the scripting that you should use to get your best possible patient paying for it out of pocket for both LBR and Curatage. If you show the value of it, then those patients are willing to pay that additional over what you're getting relative for their standard SRP or prophylaxis. I wish I had a better answer for you, but believe me, we have researched this. We've gone to the American Dental Association. Hopefully within the next year or two, we can see that we can get them to see the value of what we're trying to do.
Excellent. Thank you, Dr. Lau. And that takes us right to 4 o'clock Pacific. So as much as I would like to get to some other questions, unfortunately, we just don't have time. Dr. Lau, are there a couple slides at the tail end that you'd like to touch?
A couple of things. If you look around now, because of the environment, if you are interested in lasers, please be looking at packages that laser companies may afford. This is just one example of capital equipment, or where they're, a company appreciating the situations that we're in with our overhead and reopening. So please be looking if you're going to consider engaging and going a little further with investigating, that there are several packages that are out there now, with not paying till 2021, cash back, and also be looking for education to where now there's going to be in-office education. In other words, I think companies are appreciating that you don't want to get on a plane just yet. So be looking for companies that are going to afford you packages by which the trainer, like Steve, the trainer that Steve gets on the plane, and sorry, I shouldn't have said that, especially since the family is listening, but Steve gets on the plane and Steve comes to you and trains you to ensure that if you're going to make the investment, that you're going to do it well. This is my email. If you would like the Wednesday presentation, or if you would like my yesterday presentation about putting what we're going to do relative, and I go through HVE, I go through everything. While I'm at it though, because Steve, your cases were wonderful. But Steve, would you mind telling the group your email? Because I think there may be some laser users that may want to have some conversation with you. So could you do your email for us?
Sure, no problem. So the email is Dr. John, DRJOHN, at Stephen John, STEPHENJOHN, if you do email me though, put in the subject line, put down ATC. in the subject line. The reason why is I get so many emails that if I don't recognize who's from whatever it is, I just delete it. So if you write down ATC in the subject line, then I'll know it's something relative to these seminars. I'll be able to go ahead and answer them.